I am Dr. Amdekar. Friends, in this series, in the last few videos, you have now learned how a history can achieve not only the anatomical but also the pathological, etiological, and functional diagnosis. However, not every time a presenting symptom, especially an isolated single symptom, could really pose a problem to define anatomy and further even pathology and etiology. And in this video, I am going to discuss few very vague symptoms with which often patients present, especially in the earlier phase of the illness, much before some other symptoms arrive. And that's quite a challenge. Let's take an example of a generalized weakness. Often patients come with this statement and we need to really dig into details to find out what really the patient means by generalized weakness. At times, a thin person is equated to be weak person. We know all that is not right. And at times, a weakness may refer to a paresis, a neurological symptom. And once you confirm that this is neither of the two, then you start working further into the questioning and find out that what he means by generalized weakness is really he is getting tired even to an accustomed exertion. Now once you know that he is getting physically tired, the anatomy is clearly the muscles and the general involvement of all muscles. Once you know, pick up the anatomy, the next is to make sure whether it's a primary muscle disease or the muscle is getting affected through other systems. Now, a typical two primary muscle disorders are either inflammatory, like myositis, where in this patient there is no pain or fever, or a myopathies of different types, which really present as a neurological disorder and often not very generalized and suddenly appearing. And hence, once you know that these two kinds of pathologies are ruled out and they are generalized weakness, so it cannot be tumor or any such different pathologies that we have learned from, then you start wondering whether these could be a normal structured muscles but are functionally getting weaker. Once you understand that this generalized weakness without any obvious structural changes and therefore are not a common pathologies that you learned during one of the last videos, we start looking at why is the function disturbed. And for that, you get back to physiology and say the muscles need oxygen, glucose, and also some electrolytes like intracellular ions like potassium, magnesium, and so on. Then you start thinking, if it is a lack of oxygen, then it must be either a respiratory disease, the lungs produce oxygen, or it could be a chronic anemia slowly developing because oxygen is carried by hemoglobin, or it could be a very slowly progressive cardiac problem because the heart is pumping the blood to reach the oxygen to the muscles. Friends, then only such thought process can make you understand that the pathology could be non-structural but only functional, and a chronic slowly evolving respiratory, cardiac, or even a hematological disorder could just present as a generalized weakness. What about glucose? Majority of the times the hypoglycemia is an acute event, though rarely it could also be chronic, but the body has a lot of reserve to take care of, and when the sugar goes very low, then suddenly there is an acute event. So if this generalized weakness due to a low glucose is going on for some time, then obviously it is a hyperglycemia like diabetes, where there is the excess of sugar in the blood but there is no uptake by the cells and therefore the cells suffer a low glucose. If you know this and if you think about this, then only in this patient you are going to ask whether he also has a polyuria, polyphagia and polydipsia. And then finally, it could be intracellular electrolytes, though it's certainly not common for a chronic hypokalemia to only present as generalized weakness, but yes, it does occasionally. And then you know that it's often due to a renal metabolic disorders, and so then you start thinking whether there is any clue to the probable renal etiology. What I meant was this symptom of general weakness is to find the anatomy as a muscle does not stop there, but to find out what kind of functional abnormalities there could be, and you will have to ask the relevant questions related to a respiratory, cardiac or hematological disorder as well as diabetes and electrolyte disturbance. Well, but sometimes, friends, it may not be so easy because the symptom could be so vague that it could arise from anywhere in the body. For example, a patient comes saying that he feels malaise or he has a loss of appetite for last several days. It's some body's dysfunction, but we don't know where it is coming from. And in such a case, you understand that if it is acute, then something acutely coming up. For example, if somebody suddenly comes home from work or from school and feels that, oh, he is not up to the mark and he doesn't want to eat, he may be coming out with fever and a simple viral infection the next day, and you know next day what the problem is. But sometimes the problem like loss of appetite or malaise continues for some days or weeks, and then you will have to consider which hidden infection or hidden organ dysfunction is likely to be behind this, including a hidden malignancy at an old age. And once you know that a chronic hidden infection like tuberculosis could present with just a loss of appetite and no other symptom, then you start asking some detailed history where the TB could be, and then also ask whether there is obviously a contact with an open case of tuberculosis. Similarly, if it's a chronic hidden organ dysfunction, like a renal organ dysfunction, it's often very hidden, and you need to pick up whether he has not been growing well for a long time, or whether he has really sometimes some mild edema, or a chronic liver disease where he has an abdominal distension. But all this comes forth only if you give a thought which system could be involved in such a vague symptom like a loss of appetite. And of course, in old age, the malignancy, and you start wondering where could a malignancy be totally hidden without any other symptoms other than a constitutional symptoms like a loss of appetite or malaise. Friends, such vague symptoms really pose a problem, not only to find the anatomy, but also further to find pathology. Like in a generalized weakness, it's the functional disorder but not a structural disorder, so it's not easy to pick up. Further, occasionally, you know the anatomy very well, like a nausea for example. It's some gastropathy, but if it's an acute, then you start wondering whether he is going to come out with a simple viral A hepatitis and he has severe nausea. But if it's going on for a long time, then you start wondering what it is, and sometimes such problems may be even psychogenic, at which time you get into the details of asking personal history, whether he sleeps well, whether his bowels, urine are alright, whether his moods are alright, and whether such symptoms come only at a convenient time whenever he wants not to do something. And I think even a psychogenic problem can present like this. Finally, a hiccup is another symptom. You know, hiccup is due to a diaphragmatic contraction, but to find a pathology or etiology is nearly impossible. All that we know is something near the diaphragm, either above a lung or a pleura or below, say, a distended stomach, could irritate the diaphragm, but most often such hiccups stop by themselves. But occasionally, a metabolic disorders or chronic renal disorders could also cause such hiccups. Friends, in this video I wanted to kind of address issues where not all symptoms are easy to pick up anatomy and pathology, etc. But even then, some detailed thought process, and that's what the STEER stands for, sensitizing to think, can make us arrive at a probable diagnosis. In the next video, that's the last video of this series, I will again sum up all that we learnt in the last 7 videos. Thank you very much.